This podcast is brought to you by the IIEA, sharing ideas, shaping policy.
Good afternoon, everybody, and a very warm welcome. My name is Barry Colfer. I'm the Director of Research here at the Institute of International European Affairs. A very, very warm welcome to our panellists, to our moderator, and indeed to all of you here joining us in person, in full Technicolor in Dublin, and those joining us online. Delighted to welcome you to this session on Ireland's EU Presidency, leading Europe's public health agenda. I wanted to start by very briefly acknowledging the support of Sanofi Ireland, without whose support this event wouldn't be taking place. So very much appreciate your support and our ongoing work together. European integration began in 1951 amid the ashes of the war, where the focus, as many of you will know, was coal and steel. This paved the path to 1957, the Treaty of Rome, which is the route from which the modern EU can trace itself with the Europe's Economic and Monetary Union, the European Economic Community. And over the 70 intervening years, the EU has moved from, fairly curtailed, limited range of responsibilities to covering almost all aspects of life in Europe and beyond. But I even remember 5, 6, 10 years ago, it was often said, it was almost a mantra, the EU covered almost everything, but left alone education, social protection, security, and health. And we've seen over this past number of years how the EU has become increasingly significant across each of these policy areas, not least with respect to public health and the regulation thereof. So I think it's with the prospect of the Irish presidency forthcoming, for which we're all extremely excited, needless to say, I think the importance of these conversations around Europe's role in public health, Ireland's role within the EU vis-a-vis public health, are only increasing in terms of its significance. And indeed, our role here at the Institute is to try to provide visibility to these important discussions around the betterments of life here in Ireland. It's hard to find, I think, a topic of more importance vis-a-vis the betterment of society in Ireland than public health. So I'm really, really pleased that we have a really esteemed panel with us today to discuss this. I just want to very briefly acknowledge Professor Breda Smith, who's a professor of public health at the Royal College of Surgeons in Ireland. Professor Smith is going to moderate the discussion today. Thank you most sincerely for your time. Not only is Breda a significant professor and research scholar in this area, but of course also a previous Chief Medical Officer of Ireland. So who better to handle such an important discussion? It's only for me to mention a couple of words of housekeeping. This discussion now is all on the record. There will be an opportunity for questions and answers, whether in person. Just indicate by raising your hand or by signaling to one of the guys in the room with a mic, and you'll be able to add your question or comment when we get to the time. Those online, you can use the Q&A function on Zoom. The final thing just to say to our panelists, you're all mic'd up. You can stay where you are during your discussion once you give your remarks, or indeed you're welcome to take on the podium either way. And just to say thank you most sincerely again, I hand over to you, Dr. Smith, to do the official introduction to our panel. Thank you.
Thank you very, very much. And it's a great privilege for me to be here today for this very important topic, and also I think a very exciting time for Ireland, where we can have a real impact on European policy with regards to health and the future of healthy populations within the EU. And this is a very, I suppose, a topic that's close to my heart. So it's Ireland's EU presidency, leading Europe's public health agenda. And I'm really delighted to be joined on stage here by José Luis Castro, Director General, Special Envoy for Chronic Respiratory Diseases at the World Health Organization. Also Professor Mary Horgan, Chief Medical Officer at the Department of Health. Mark Canavan, EU Public Affairs Senior Director at Sanofi. And Mandy Daly, who is founder of the Irish Neonatal Health Alliance and embedded patient researcher. We will start with José, who will give a keynote address to us for 15 to 20 minutes. And then we will continue with opening thoughts from each of our panelists on the theme of today's discussion. After this, we will have a panel discussion, and then we will open it to the floor, both you in attendance, but also all of you that are online. And we will alternate questions potentially between the room and the online population. So I suppose without further ado, I'm not going to keep you from the important conversation that needs to ensue. I'm going to ask Jose to take his place, and we look forward to his address. Thank you very much.
Thank you very much for the kind introduction, and good afternoon to everyone for being here today in this important meeting. And I would like to say thank you to the Institute of International European Affairs and to Sanofi for convening this important conversation. It is an honor to join you here in Dublin and to take part in a discussion about Europe's public health future at such an important moment. Dublin is a city that understands the power of ideas and the power of honest reflection. From Jonathan Swift to George Bernard Shaw to James Joyce, this is a place that has never been afraid to take a long, clear look at the world and to ask difficult questions about where we are going. So today we gather in that same spirit to take a clear look at something that too often escapes our attention: the growing burden of respiratory diseases across Europe and around the world. Earlier this week, the world marked World Tuberculosis Day. It commemorates the discovery in 1882 of when Robert Koch identified the bacterium that causes tuberculosis. It was a breakthrough that changed the course of modern medicine and public health. And for many countries, including Ireland, tuberculosis was once among the deadliest threats that people faced. In the late 19th century, roughly 1 in every 8 deaths in Ireland was caused by tuberculosis. Families lost parents, children, and neighbors to a disease that seemed relentless. And the remarkable progress since then is one of the great achievements of public health. Though through science, prevention, treatment, and political will, society has dramatically reduced the toll of tuberculosis and other respiratory illness that once dominated mortality. And I want to emphasize that while in the developed world that has been the case, tuberculosis is still the leading infectious disease killer in low and middle-income countries. But that progress also teaches us an important lesson. Respiratory disease did not disappear. It evolved, and today it remains one of the largest and least recognized health challenges facing humanity. Around the world, chronic respiratory diseases, including chronic obstructive pulmonary disease, asthma, and other conditions, affect more than 500 million people. Chronic obstructive pulmonary disease alone affects more than 390 million people globally and remain one of the leading causes of death worldwide. Every year, millions of families lose someone to diseases that limit the most basic human function, the ability to breathe. Breathing is the most fundamental act of life. It is something that we do more than 20,000 times each day without thinking. And yet for millions of people living with chronic respiratory disease, every breath becomes an effort. Every step can feel like climbing a hill. And these diseases often develop slowly and quietly. They are shaped by the air that people breathe, the environments they live in, the policies that govern public health, and the choices that societies make about prevention and care. That is why respiratory health is not only a medical issue, it is a policy issue, an environmental issue, and increasingly, it is a question of economic resilience. In Europe, we are facing a set of pressures that make this challenge more urgent than ever. Populations are aging, health systems are under strain, climate change is affecting air quality and respiratory risk in new ways. And the lessons of COVID-19, which reminded the world how vulnerable we remain to diseases of the lung, are already beginning to fade from the public attention. Momentum for coordinated public health action across Europe has slowed in recent years, yet the need for cooperation has only grown. Respiratory diseases do not respect borders. Air pollution travels across countries. Pathogens spread quickly in a connected world. Data research and prevention strategies must move just as quickly if we are to protect populations effectively. This is why Ireland's upcoming presidency of the Council of the European Union presents such an important opportunity. Presidencies have a unique ability to shape priorities, to elevate issues, and to bring together governments and institutions around shared challenges. Public health and respiratory health in particular deserve a central place in that agenda. Ireland itself offers example of how policy leadership can transform public health outcomes. Later this week marks the anniversary of Ireland's landmark nationwide workplace smoking ban in 2004, the first of its kind in the world. When that policy was introduced, many questioned whether it could succeed. Yet it became a global model, demonstrating that decisive public health action can reduce harm, change social norms, and protect generations to come. Policies like that remind us that prevention remains one of the most powerful tools that we have. The best treatment for many respiratory diseases is to prevent them from developing in the first place through cleaner air, tobacco control, early diagnosis, and stronger surveillance systems. There is a Gaelic saying that feels especially relevant to the challenge before us. And before I say it, I excuse myself for pronouncing the Gaelic, but I will try. I had assistance. Arska Akela Vadin Dina. I don't know if I succeeded, but it's in English is people live in one another's shadow, or more simply, we depend on each other. Public health embodies that idea. The air that we breathe is shared. The health of one community affects the health of another. The success of prevention efforts in one country can prevent the lives far beyond its borders. That spirit of shared responsibility is also at the heart of the European project. Cooperation among nations has long been Europe's greatest strength. In the field of public health, that cooperation must continue to deepen through stronger surveillance systems, better data sharing, coordinated prevention strategies, and support for innovation in diagnosis and treatment. The fight against respiratory diseases is not only about responding to illness. It's about building health systems that are more resilient, more equitable, and better prepared to for the challenges of the future. Cities like Dublin understand that progress often emerges from adversity. Through its history, this city has faced epidemics, public health crises, and social upheaval. And each challenge left behind something valuable: stronger institutions, better science, and a deeper commitment to protecting human well-being. So today, we have an opportunity to apply those lessons on a broader scale by strengthening collaboration across Europe and connecting it with the global public health efforts. We can accelerate progress against respiratory diseases and continue to affect millions of lives. If the past century taught us anything, it is that progress against diseases of the lung is possible. Tuberculosis once dominated mortality statistics in countries across Europe and the world, and today, although it continues to be a leading infectious disease killer in the developing world, it is treatable, and it is preventable because society is invested in science and policy and in collective action. The challenge now is to apply that same determination to respiratory diseases that shape our time. Because the ability to breathe freely should not depend on where someone is born, the air that they are forced to breathe, or the strength of the health system available to them. It should be a universal expectation. So Ireland's leadership in the coming European Union presidency offers an opportunity to renew that commitment, to bring respiratory health back to the center of the public health conversation, and to remind Europe and the world that protecting the simple act of breathing is one of the most fundamental principles of public policy. I thank you very much on behalf of the World Health Organization, and I look forward to our discussion today.
Thank you very much, Luis, and some significant food for thought there with regards to, yes, the ability to be able to breathe clean air is a human right, and health is a human right. So next, I'd like to introduce Professor Mary Horgan, who's going to say a few words on the topic.
Okay, that's great. Thank you very much, Brita. Firstly, I'm delighted to be here today. I think this is a particularly fantastic opportunity. And from the Irish government point of view, they've made it very clear that they want this presidency to be a success. So for those of you in the audience, you remember the last presidency was in 2013, and the next one is in 2039. So these next 6 months are really, really important. From a Department of Health point of view, and I always think that you shouldn't look at health as a siloed, isolated department, but healthy populations, a healthy economy, and vice versa. So we certainly work very closely with other government departments in putting together the programme that will serve as part of the EU presidency. The high-level theme within the department is investing in health to enable competitiveness. And again, highlighting if you have a healthy population, healthy educated population, and it really aligns with the overarching EU priorities, which are value, security, and competitiveness. The health agenda makes it clear that population health and well-being are fundamental for European security and competitiveness. And while we think less maybe of security than some of our member states in mainland Europe, it is still really important, and it is integral to everything that we do. We do have demographic challenges, and while I always hear that we have an aging population, Ireland has one of the youngest populations in the whole of the EU, with about 25% of our population being under the age of 18. So that focus that we have in the Department of Health of looking and really giving every child in this country the best start as possible is really important. And we've been very involved with the Department of An Taoiseach in working on child poverty and other areas that are really important as people age. This will be mentioned later by Mark, but our presidency will progress 2 major EU legislative files that would shape health and life sciences for decades. And they are the Biotech Act, which really will strengthen what we do and make us more competitive and probably more self-sufficient in Europe when it comes to pharma and other aspects that are important to our biosecurity and ensuring that our population is healthy. And the second one is the amendments to the medical device regulations, which is very pertinent, particularly in a country that leads in this, not only in Europe, but also globally. These initiatives will not only reshape how medicines and med tech are developed, regulated, supplied and accessed in the EU, but they will directly address EU structural competitiveness gaps, and I'm happy to go into those gaps. The other thing that is really important that was signed off is the EU Cardiovascular Health Plan, and that was signed off in December 2025. We particularly welcome what is known as the Safe Heart Plan, which really focuses not only on the disease itself, but really prevention, innovation, and health equity to improve cardiovascular health. And these align with our ambitions in the area. We do support a life course approach to disease prevention, and while it's important that to note that we do have long lifespan, it's not just about the quantity or the length of life, but the quality of the life that we live, particularly in older years. So that focus on primary, secondary, and tertiary prevention is really important. Tobacco products are one of the main risk factors for cardiovascular disease and, of course, respiratory disease. And as you know, Ireland have led in this area. We were really keen to get the tobacco products directive, but it may not happen during our presidency, but we will continue to lead in this. And just to note, yesterday we published the first of file on banning of commercial sunbeds, the working group that the scientific background for that, for the most common cancer in Ireland, is a particular focus, and Minister Mairead O'Connor, the Minister for State with responsibility of public health, accepted that, which is the first major step in dealing with that prevention issue. There is a number of other areas, and it's really been busy in the department, organising a number of symposia at high level, not only within the Department of Health, but working with other departments and our aegis bodies to deal with areas like, I suppose, our innovating with purpose. We are a country of innovators. We stand out, and we need to showcase that to our EU member states and beyond. Advancing integrated care across the European Union, and when you visit other countries, we do stand out in driving care to where it's most needed. That is to into the communities where people actually live in their real lives, and how we can work on health system resilience and population well-being. And particular focus of mine is emerging health threats and our preparedness for that. Again, a health threat is not just a health threat, it's a threat to how we live as a society and our economy. We're developing a series of high-level ministerial events and conferences, and they will include prevention, innovation and health equity, medicines access and clinical trials, which we had a discussion about really earlier, and how we can be more flexible, adaptive and competitive when it comes to clinical trials, not just in Ireland, but in Europe. Digital health and data, One Health and climate change, and again, that links in with Jose's and in fact, Alex White's new position. Look forward to speaking to him on that. Mental health, that isn't separate from, that's part of our health, mental and physical health are together. Women's health and endometriosis, which is a particular high priority for our Minister for Health. Just to give you some ideas of the proposed high-level ministerial conference on prevention, innovation and health equity, currently titled Maximising EU's Potential Through Health, Securing Our Future Through Prevention, Innovation and Equity, really highlighting that investment and more investment in prevention is really, really important. It's only about 6% of our EU health budget. There are a number of other areas: strengthening Europe through NCD, non-communicable disease prevention, ensuring health equity and scaling innovation. with the understanding that those most marginalised are those most at risk for every single health issue that's there. And that focus as a country that really drives equity across whether you're new into our country or you live here is incredibly important. Commercial determinants of health is another focus of ours and should be more and more highlighted with what we do, what will be part of our agenda during our presidency. And strengthening early detection and screening of cardiovascular disease as part of that safe health program is really important. Again, our screening programs do stand out as exemplars of how screening should be done. Our immunisation uptake is higher than most European countries. I think sometimes you think we don't do very well, but comparatively, a huge amount of work is done, not only by our healthcare professionals, but by our advocacy groups, by our patients, by the public, who are really good at getting that message out to our population, particularly those that are hard to reach. So that patient voice, which will come up here, is really, really important. So just finally, our two ministerial panels to be debated on our stronger systems, fairer outcomes, focusing on prevention and innovation for a secure health future in Europe, and harnessing our EU structures to ensure policy agility, which I think is really important, and innovation. Thank you.
Thanks very much, Mary. Thank you. So next we're going to move to Mark Canavan, EU Public Affairs Senior Director at Sanofi.
Thank you very much. Thank you for having me today. I'm delighted to be back in Dublin. So I'm based in Brussels, and every day we're now having conversations about the priorities of the EU presidency, particularly in health and pharmaceuticals. And without doubt, as Mary mentioned, the core focus will be around competitiveness. You can't move around a corner in Brussels without hearing the word competitiveness, and it's for good reasons. Particularly, the focus will be on clinical trials, which is really, I think, great for Ireland, that we will be leading the legislative reforms which are really needed in that area. I also think, and this is what I would like to speak to today, that the Irish presidency has a real opportunity to leave a very significant and concrete legacy in public health in particular. And three areas which I would identify, which are more or less scattered throughout the various policies that Mary mentioned, are around vaccination, so setting particular goals and targets at an EU level. Around, I think, also this more important strategic debate about EU sovereignty in public health, which has really emerged in the past year, and is I think very, very important that Ireland starts those conversations with other member states during their presidency. And then, as Jose mentioned, in addition, there's a lot of high burden diseases, particularly in the respiratory disease space, which in fact there's very, very little EU action on. But I think Ireland has a good opportunity, given its credibility on respiratory illnesses, its legacy in public health around smoking cessation, that we put those on the agenda and advance that agenda. So just to step back for a moment, Barry very much referenced this at the start, and it's what you generally hear in debates about EU and health. But the EU has very limited powers, in fact, in health coming through the treaties. And that's quite a surprise, because we know, we feel that the EU actually now in all healthcare debates, I think that we have. In some areas, such as the regulation of healthcare products, of pharmaceuticals, for instance, the EU has very, very strong powers. In other areas, such as healthcare disease area policy, really very, very limited powers. And then in public health, I would say they have mixed powers. So you see very strong powers in times of crisis, but very surprisingly to most people, I would say limited powers in peacetime. And in areas which Jose and Mary both referenced, which are core public health functions, such as surveillance and data sharing across borders on infectious diseases, You see, in fact, member states resisting mandates in those areas. National public health systems really, you know, they I suppose guard very securely their competencies in those areas. So that can create, you know, difficulties, I suppose, in having more substantive public health programs at an EU level. Even so, I think there are really quite concrete and good examples of what works at an EU level. So 2009 flu recommendation, I think, is one you hear a lot about this year, and for good reason. So that was a political objective that member states agreed to voluntarily meet, and it's that they would try to meet 75% or try to vaccinate 75% of their population against flu. Now, it's not been momentous. It's been in place for, you know, decades. Ireland and Denmark are the only ones who actually meet the target. But in actual fact, it's a good example of one that has, you know, galvanized healthcare systems. It's a metric, and it's sort of a moral tool, if you will, for promoting vaccination in national healthcare systems. The debate is open this year through cardiovascular plan and other measures of expanding that to include all respiratory infections. And we know respiratory infections are the things which devastate hospitals every winter. So it stands to reason that we would have targets across the EU on these infectious diseases. It's quite remarkable when you think about it, that 6 years after COVID, we still don't have agreement amongst member states about what we should be vaccinating our populations against for COVID, as low as 5% last year in some member states, COVID boosting. Ireland, I think, has a really, really extraordinary background in vaccination and is a credible leader in this debate. We can provide lessons from newer vaccination programs. So, for instance, the RSV program, Ireland started in 2024, remarkable success. I think instantly in the month it was introduced, there was 500 fewer infants hospitalized due to the introduction of this vaccination. There's still a good quarter of member states without RSV infant vaccination. So I think having that conversation, putting in place a recommendation and a target on the EU level is a concrete measure that Ireland can take leadership and advance during its presidency. As I said, another area I think that Ireland can start the conversation on, and it's a very current one, is around public health sovereignty in the EU. So the EU has relied, and you know, still relies very much on international systems via the WHO for surveillance, for strain selection, and also even for vaccine development and manufacture. We've seen the risks of that over since really the changes in the US administration, and really it is a sovereignty issue for Europe, I would say, at this point in time. So there needs to be a conversation about what Europe needs to do to be able to stand on its own 2 feet. It's not an alarmist one, but Europe needs to think about how to bolster its public health sovereignty. So I think, again, Ireland can start the agenda, start the debate on that. It's not a piece of legislation, but it's really a discussion. And then finally, just to briefly touch on chronic respiratory diseases. So as I said, there is no EU respiratory disease plan, despite the high burden that diseases like COPD have across member states. It's, I would say, a textbook example of an area which would benefit, which there will be high value from a European strategy. So there's high underdiagnosis, as much as 80%, I believe, in some member states are underdiagnosed COPD. Huge burden on hospital systems, and we also see huge inequalities across member states, and that's really the signature for what would benefit from better EU coordination. So I think 3 areas, very concrete, in addition to all the legislation Ireland will advance, that would, as I said, leave a very lasting signature achievement of the presidency.
Thank you very much, Mark. So next I would like to introduce Mandy Daly, founder of the Irish Neonatal Health Alliance and embedded patient researcher.
Thank you. Good afternoon. And thanks to the Institute for the invitation to have this conversation here. I'm here today wearing many hats. I'm a parent of a preterm baby that was born 20 years ago. She was born at week 25 of pregnancy. That experience led me to found the Irish Neonatal Health Alliance. And since then, I've had 20 years of experience working across advocacy, education, healthcare, research, and policy. I know firsthand what it's like to live with preterm birth because I've lived with it every day since the 8th of October 2006. Preterm birth doesn't end when those children go from hospital. It doesn't end at age 2, which is the time point that many families are told their infants will catch up with their peers. For many of us, preterm birth is for life. My daughter Amelia suffers with a chronic respiratory condition called bronchopulmonary dysplasia, and her experience reflects the reality of so many adults who've been born preterm across Europe. Respiratory vulnerability, ongoing health needs, and a lifelong legacy of her early experiences. And this is why conversations around Europe's health policy are so important, that they include people with lived experience, because we know that policy is strongest, it's more meaningful, and it's relevant when it actually reflects real life. The neonatal unit for me is the beginning of public life, public policy. Everything that happens in those early days actually influences the respiratory trajectories right across childhood, adolescence, and adulthood. Prevention, early diagnosis, surveillance, long-term follow-up, they're not abstract policy concepts, they're daily realities for families. And when we talk about resilient and future-ready health systems, we have to think longitudinally, and we have to design systems that actually recognize that these outcomes unfold across a lifetime. So for the last 20 years, I've been working in advocacy as a researcher and as an educator. And a central part of what I do is demonstrating the added value of lived experience to shaping healthcare policy, to designing research and developing curricula for healthcare professionals. And what we see consistently is that when patients are engaged early, decisions are more meaningful. When patients are embedded, systems change. And when patient input is sustained, outcomes improve. And this is really important for respiratory health, where prevention pathways, access to innovation, adherence, long-term management, they're deeply influenced by real-world experience. For the last number of years, I've been fortunate enough to be involved with the RSV Pathfinder program, both in the health technology assessment aspect and also with the evaluation of the program. HTA is often viewed as technical, economic, evidence-based, and it is. But patients can change the questions that are asked during HTA processes. Patients can also highlight outcomes that aren't captured in those data sets during the discussion. So things like caregiver burden, long-term consequences, quality of life, access to innovation. In respiratory health, these perspectives are really important for evaluating preventative strategies, therapeutics, diagnostics, models of care. And again, I've been so fortunate in my 20 years that I've been involved in the development of several models of care. I've been involved with clinical guideline development, and I've been involved with 3 different agencies with doing clinical audit. My experience, though, is not typical of a patient. There are so many disease areas that do not have somebody like me within them, contributing right across the spectrum of healthcare, research, and education. But patient insight doesn't actually replace evidence, it actually supports it and completes it. Another important development that we're seeing across Europe actually is the growing strength of advocacy and collaboration across borders. So we see patient organizations more and more working together, sharing evidence, aligning messages, contributing to European policy discussions. And this is really important when it comes to respiratory health and preterm health, because all of our challenges are mirrored across borders. They're no different. And in Ireland alone, we have more than 3,500 babies born preterm every year. Globally, that's over 13 million. And I would query the percentage of that real world data that is being used to drive policy. For me, European cooperation needs to expand beyond data and innovation. It needs to expand its remit to draw in that patient experience data, that lived experience, that real world evidence. And there's a real opportunity during Ireland's EU presidency to champion this cause and embed meaningful patient engagement as a standard component of public health policy and programme design. So how do we do that? For me, it's about embedding patient advisory groups, patient partners within our respiratory health programmes, not at the consultation at the end, but right at the start as equitable partners. Patient advisory groups, they can ensure that programs reflect real-world needs. They can address barriers to access. They can anticipate unintended consequences. And more importantly, they can keep those programs focused on what matters to patient communities. And when lived experience becomes the driver, we see more relevant research, more implementable policy, and more equitable care. So what does this mean for Europe's health policy? Well, for me, it's recognizing that respiratory health starts at the very beginning of life, in those very early days. It's designing prevention and monitoring programs that follow people right across their life course. It's about ensuring that access to innovation is informed by real-world evidence. And most importantly, it's about embedding patient partnership as an infrastructure and not as an aspiration. Because if we're looking at for future-ready systems, we have to build them with the people who are going to live within them. Reflecting back 20 years ago, for the first 4 weeks of Amelia's life, I spent every day at her incubator. She was on life support. Her prognosis was unclear. And I wondered if we had a future, and also what would that future look like. Today, I've had a career change. I work in healthcare research advocacy, shaping that future. And the distance between those two endpoints is patient partnership. Lived experience is not anecdotal. It's strategic intelligence for public health. And I think as Europe looks forward, ensuring that policy is informed by those who live with its consequences is really important to building resilient, appropriate, and equitable respiratory health systems.
Thank you very much, Mandy, and a very important reminder of the I suppose the phenomenal impact and importance of patient involvement right from the very start. So now we're going to start our panel discussion, and first of all, I'm just going to, I suppose, offer the questions. I'll ask a few questions of the panel, and whomever wants to jump in, feel free. So the first area that strikes me, and of course, as a public health practitioner, equity is very close to my heart. And we know that respiratory diseases affect disproportionately the lower socioeconomic classes. They have higher tobacco consumption, generally are exposed to poorer air quality. So how do you think we can address this?
Well, you've been in my role before, Breda, so there are a number of ways you do it. And as I said before, it's not just a health issue. When you look at things like poor air quality, that's not just health, it's environment, EPA department. So I think that those relationships are really important. I think it's being bold in the vision to do something differently and innovative, not doing the same thing all the time. And things, you know, I mean, I suppose the opportunity of advancing the tobacco directive would have been really good for us because we have that track record in doing it. We're seen as leaders in that area. And there are the bold things that we need to do, not doing more of the same. Assuming that the results are going to be different, you have to do things differently. I think bringing in people with the lived experience, because they know what's happening on the ground. I think a lot of the time, as you know, educated middle class people, you see people in a clinical environment that's artificial. You don't see how they live, and the environment which we live, not just the genetics, but the environments in which we live are really important. So having that understanding is important. We can't do that in public health alone. You have to reach out to other departments, other aegis bodies within Ireland, but also see the good things that are done elsewhere and vice versa, and have that knowledge exchange. And there's no point in reinventing the wheel when other countries, member states, are doing things that we could I wouldn't say copy and paste, but kind of do that and make it suitable for the way in which we live in this country. I think when it comes to public health and the EU presidency, and what's important, and we should be thinking of this all the time, is what policy decisions can we make that will be impactful on the citizen, the person walking on the street anywhere in Europe? And we do have challenges because people live differently, and there are different government priorities. But when we, develop high-level either policies or symposia, I think everyone coming to those when we're hosting them should be able to go back and see what impact that has on the citizen, the people that live and elect people, through democratic process. So the decisions that are made are impactful. Thank you, Louise.
Completely agree with what Mary said, and also want to add that sharing the information about access to diagnostics and understanding the symptoms, understanding the risk factors that affect them and where to seek care and when is so important. Many patients with chronic respiratory diseases access the system very late or are sometimes often misdiagnosed or given incorrect information. So understanding where to go for help and having those services available is important. And it's not only putting the burden on the patient, but also on the practitioners as well, educating the primary care physicians also to suspect that when the patient in an area where there's high pollution or smoking, to require the patient to have a lung function test.
Very concrete suggestion there. Thank you very much. So we've spoken even in your answers there a good bit about innovations and then also, Louise, you've brought up the idea of data and surveillance. And we know from a European perspective and the WHO, there have been multiple documents and strategies recently published about digital health and AI, and likewise here in Ireland. So how do you think that can feed into the overall agenda, public health agenda, that we can influence during this presidency?
Well, I believe that I think we need to be able to measure, the countries need to be able to measure the impact of these diseases. What is not measured does not get prioritized. And I think that's one of the challenges that we face with chronic respiratory diseases. For example, the other European level, the European Respiratory Society and WHO regional offices published a report on chronic respiratory diseases, and it's one of the first reports that were published in the world on this particular diseases. But the importance of collecting data and sharing that information with the public and policymakers is not a luxury, something that should be a priority for every member state.
Mark, would you like to come in on that?
Yeah, there's probably two things I'm thinking of. So with regards sharing non-communicable diseases like chronic respiratory diseases, the EU recently in the last 5 or 6 years innovated a really quite, I think, a good idea, which is a cancer inequalities register. And that it's only up and running, but it has, I think, a good function in terms of spotlighting the inequalities that exist in cancer outcomes, and then potentially can be used up the line to look at inequalities in centres of care and in access to therapies and things like that. I think that's a good innovation for disease areas like chronic respiratory illnesses as well, and very, very practically could also be done quite in a 3-year time frame with innovations like the EHDS and obviously with AI as well. When it comes to infectious diseases, I think it's a bit of a black box, the surveillance system we have in Europe, and I don't think it's adequate for our purposes. The ECDC has a very strong mandate with regards notifiable diseases. With regards to non-notifiable diseases, it doesn't have a strong mandate. And as I said, member states, sure, they share data, but at what time? It's not a very real-time information system. And it also is it's not like, you know, they would have in the United States. It's not very usable for things like other uses outside of public health uses, such as vaccines assessment, even looking at, you know, early stage R&D and things like that. And there's no real reason for that, I dare say. So I think that's type of areas that we need to look at in the surveillance system in Europe.
And I suppose the European health data space should help to move that agenda forward.
Yeah, absolutely. But again, like I really don't think why member states they don't share earlier infectious disease notifiable data with the ECDC isn't necessarily a EHDS issue, I dare say, but it should certainly help. Yeah.
So Mandy, just with regards, you spoke a lot about the impact of patient involvement, really, and its value, really. With regards to prevention, how do you feel that your voice should be included more?
I think we need a culture change in this country, and we need it to happen right across the system. So, like, as I alluded to, I'm incredibly fortunate. I'm still here 20 years later, and at this point, I probably annoyed so many people, they've just let me work with them. It shouldn't be like that. I think we need to actually embrace the public voice, the patient experience data, because as patient organisations, we are best pitched to reach those underserved communities. So in terms of, even just take my own very small area of neonatology, preventing preterm birth can happen, but it can only happen through education programs. And the reason I set up the organisation is because nobody was doing this when I had my child. Nobody was there to help me understand what was happening. How could I have stopped it happening for me? And we still have a huge reliance in this country on patient organisations. Our health system, our education system, our research system is still reluctant to engage with the patient voice and the patient community to help them co-design, co-produce these prevention strategies. It's only from learning and living an experience that you actually can bring ideas to the table to help make it better. And I think that's where we can help in terms of looking at prevention going forward. It's by listening to people's lived experience and using that and turning that into something positive is where we should be looking towards. Yeah.
Thank you. And I've just one element that has intrigued me listening, and I know we've spoken about you mentioned, Mary, about the heart strategy here in Ireland, and I think one of the other panelists mentioned an EU cardiovascular strategy. So I'm getting the sense that there is a feeling that respiratory diseases are the correlation here. Why do you think that is, and what do we need to do to change that?
I think one of the major issues over here is not an infectious disease. Chronic respiratory diseases don't scare people, and that's when they don't scare people. They're not a priority in policymakers. Don't get the pressure from the public to act on them, and they're also not well understood. We have asthma, and almost anybody you mention asthma knows someone or suffers from asthma or has met a person who is asthmatic. When we talk about COPD, that's another different disease. Even among practitioners, sometimes you have to explain what the disease is and the symptoms. So it has an image problem that is quite difficult. And without that, it doesn't capture the public's imagination, doesn't capture also the policymakers' priority.
I think the big difference is the diversity of diseases, respiratory diseases versus cardiovascular diseases. Cardiovascular diseases are fairly limited to ischemic heart disease, stroke, hypertension. Whereas if you look at respiratory diseases, everything infectious diseases, cancer, inflammatory conditions, fibrosis, and it kind of reminds me a little bit of One Health. It's so big. The only way you can focus in on it is to try to prioritize and pick off certain areas so that the public understand it. And as such, then advocacy can drive that agenda of making the change. And to me, as a clinician, I think that's the biggest challenge. I see it's a big challenge with One Health, getting the citizen to understand what it is and what the priorities are. And I think the same with respiratory, because it's so big, and there's so many different causes, whereas the causes for cardiovascular disease tend to be more focused, I would think.
Yeah.
This podcast is brought to you by the IIEA, sharing ideas, shaping policy.